Good afternoon, everybody, and welcome to this ANROWS webinar titled Strengthening Capacity for Multicultural and Settlement Services to Support Women Experiencing Violence. Thank you for joining us. I'm Dr. Virginia Mapezama, and I'm a Senior Research Officer at ANROWS. I will be facilitating the discussions here today. But before I start, I would like to acknowledge the traditional owners of the lands across Australia on which we're all calling in from today. And on behalf of ANROWS, also acknowledge the Gadigal of the Eora Nation as the traditional custodians of this place that we now call Sydney. I pay my respects to elders past, present, and emerging, and acknowledge that this was, is, and always will be Aboriginal land. I also acknowledge and pay my respects to Aboriginal and Torres Strait Islander people who are viewing this webinar today and in future. I also would like to recognize that we're meeting in very challenging and unprecedented times, and I especially want to acknowledge the impact of COVID-19 on everyone. We all know that in times of crisis and pandemics, the rates of violence against women increase. So I actually want to acknowledge particularly women who are subjected to domestic, family, and sexual violence, and those people who are on the front line providing services. I feel really honored today to be facilitating this webinar, which is discussing the findings of a recently published ANROWS report titled Multicultural and Settlement Services Supporting Women Experiencing Violence. This research was led by Associate Professor Cathy Vaughan and co-authored with Karen Block, Claire Sullivan, Janine Horani, Sarah Kaur, Yara Jaralaha, Lana Zanetino, Carolyn Gregoric, Linda Murray, Mariam Suha, Jasmine Chen, Adele Medolo, and Manisha Sandhu. This project is part of our core research stream here at ANROWS, and this research stream spans domestic, family, and sexual violence, and very importantly, this stream recognizes the diversity of women's experiences in order to provide an evidence base, as well as guide policymakers and practitioners on how to best address and reflect the diverse needs of women and their children. So importantly, in the stream of research, research on culturally and linguistically diverse women and communities is very important as a target population. I also want to acknowledge that today's discussions are really timely and quite timely in light of the current global angst about racial inequality. For me, now more than ever, we need to create and encourage these spaces where we can talk about our differences and about our diversity in ways that promote safety, whether that being cultural safety, racial safety, economic safety, social safety, and physical safety, and have these discussions in these spaces without problematizing one group or another. And I'm really honored as a woman of color who's an Australian African to be involved in these discussions and facilitating them today. So I want to introduce the rest of the panel who are with us today. In the interest of time, I'm not actually going to give their full bios, but for anyone who's interested, you can find these online at the registration page. So I want to start off by introducing the Principal Chief Investigator of the research, who is also the lead author of the report, Associate Professor Cathy Vaughan from the University of Melbourne. Welcome, Cathy.
Thank you, Virginia.
Joining her from the research team is Dr. Adele Medolo, who is the Executive Director for the Multicultural Center for Women's Health, also in Melbourne. Welcome, Adele.
Thank you.
We also have several practitioners who are representing some of the organizations that participated in this research. From South Australia, we've got Daniela Foresi, who's a senior social worker from Refugee Health Services. Hello, Daniela.
Hello. Thank you very much, Virginia.
We also have in Tasmania, Xavier Lane Mullins, who is the coordinator of the Bicultural Community Health Program with Red Cross Australia.
Hi, Virginia.
Hi, Xavier. And last but certainly not the least, we have Fatima Ibrahimi, who's also from Australian Red Cross in Tasmania and is a bicultural worker in the Bicultural Community Health Program. Welcome, Fatima.
Hi, Virginia. Thank you.
Thank you to all our panelists for being here today. And before we get into the business of things, I just want to give an overview of the webinar format. So the presenters will each speak first for a few minutes. I'll ask them some questions, and then we'll actually have a live panel discussion, a live Q&A. And you as the audience can submit questions to the panel for that live Q&A. All you have to do is click on the blue icon that's at the top right-hand corner of the screen, and it'll take you to the question box. So I'd like now to invite Professor Cathy Vaughan to tell us more about this project. Cathy, you led this project. What interested you to complete this research, and can you please tell us about the aims of the research?
Thank you very much, Virginia. And firstly, I'd like to thank ANROWS for the opportunity to share this research, and particularly you, Virginia. You said you were honoured to be hosting this panel, and I'm so happy that you are. So thank you very much. I'd also like to acknowledge that I'm calling today from the land of the Wurundjeri people, whose sovereignty was never ceded, and to acknowledge their elders past and present, and any other Aboriginal and Torres Strait Islander people listening today. In response to your question about where the project came from, the first thing I will say is, as you mentioned at the start when you were reading out the names of everyone, is that the research was undertaken in South Australia, Tasmania and Victoria primarily by a large team of researchers across these 4 organisations. The team was multi-sited, multidisciplinary, multilingual and certainly multi-talented, and I'd like to acknowledge everyone's efforts. The project was also supported by 3 highly experienced and very generous advisory groups, by settlement and multicultural service providers from across the country, and particularly in South Australia, Tasmania and Victoria, and by migrant and refugee communities from across the 3 states where the research was focused. So we're extremely grateful for your support and acknowledge your deep commitment to making things better for migrant and refugee women experiencing violence. And I also want to acknowledge all the work that's being done by Multicultural and Settlement Services to support women across the whole country. The MuSeS project was underpinned by research that we'd previously undertaken for ANROWS, which was the Aspire project. And with this project, we found that because of a whole range of barriers to specialist family violence services, many migrant and refugee women could or did not access them despite wanting help. I also want to acknowledge that other researchers working across Australia have described these barriers as well, and note the hard work and advocacy that's been going on across the country for years to try and address them. One of the things that we found in the Aspire project was that while migrant and refugee women might never access a specialist violence service, many of them did access settlement and multicultural services and organisations for a range of other issues. One of the key messages from Aspire was that this was an opportunity to increase women's ability to access the information and help they needed in the case of violence when they needed it. We knew that settlement and multicultural services were supporting women who were experiencing violence, but there'd been very little research done that could be used to strengthen these efforts, and that led to the design of the MuSeS project, which specifically looked at 3 things. How do multicultural and settlement services currently support women experiencing violence? What factors strengthen or undermine their capacity to support migrant and refugee women who are experiencing violence, or to implement early intervention initiatives, including where women are in an ongoing relationship with someone who's using violent or controlling behaviours? And how do services understand and respond to the interactions between mental ill health and vulnerability to or perpetration of family violence? And I should note that this last theme, this theme within the second research question, arose directly from consultations with specialist refugee mental health services who wanted to understand how their staff and services could better respond to family violence. And finally, the MuSeS project looked at what more could be done, what opportunities were there to build on current efforts, address challenges and deliver effective interventions to support women experiencing violence through settlement and multicultural services. And to answer these questions, we conducted consultative workshops in South Australia, Tasmania and Victoria before and after data collection. We ran a national anonymous online survey of 378 service providers. And then in Victoria, Tasmania and South Australia, we conducted in-depth interviews with 47 settlement and multicultural service providers, including specialist mental health services. We conducted focus group discussions and interviews with volunteers and in-depth interviews with refugee women, and held 4 participatory workshops with migrant and refugee women, particularly looking at experiences and understandings of mental ill health and family violence and how services could better respond.
Thank you for that detailed overview, Cathy. So what did the research find?
The first thing to say is that multicultural and settlement services regularly encounter situations of family violence through the course of their work. Certainly respondents to the online survey, 92% of them said that they had encountered family violence as part of their work, and they currently provide women with a wide range of supports. They support women by providing education and information about family violence laws, gender norms and rights in Australia, and about specialist family violence response services. They also support migrant and refugee women to navigate their way through complex systems they encounter when seeking services for violence. Multicultural and settlement service providers, and particularly if they've had specific violence training, often identified a range of indicators or red flags that suggested violence might be occurring. The confidence that they had to be able to act on the basis of these signs depended on a whole range of factors, including whether they had organisational support to do so. Multicultural and settlement service providers, including volunteers and frontline workers such as orientation guides, do receive direct disclosures, and many service providers, particularly those who've had training, felt confident in how to respond and refer. But volunteers and often the casual line workers felt that they were not trained or equipped to know what was appropriate to do. And I should note that this sector is very dependent on volunteers and engages thousands of volunteers across the country. Service providers do refer and liaise with specialist violence response services, and they often work with these specialist services to advocate for women in need of financial, housing and legal advice. Settlement and multicultural services often have expertise and advocacy skills, particularly in relation to immigration issues that specialist family violence services do not. So this ongoing liaison and communication between services in the two sectors enables holistic support of clients. An important point to make is that in the course of their work with migrant and refugee communities, many settlement and multicultural service providers also encounter men who use violence. And the high level of engagement this sector has with men is an important prevention and response opportunity given the well-known service gaps for migrant and refugee men who use violence. Specialist refugee mental health services highlighted the bi-directional relationship between mental ill health and women's experience of violence, and these services play an important role in supporting refugee women and men who are experiencing mental ill health and who are experiencing or using violence. However, there are far fewer mainstream mental health services that can respond to the complex needs of people who've come to Australia as permanent or temporary migrants who might be experiencing family violence. Another area where we had a key theme in our findings was that service was in relation to what made it difficult for services to support women. And these included the difficulty they faced in trying to find appropriate specialist services to refer women to. And that might be because the services were so few, but also because specialist services might be unable to support women who do not have access to Centrelink or Medicare, and that would include some women on temporary visas, or they have limited ability to support women in ongoing relationships with the perpetrator. A key factor undermining the ability of settlement and multicultural services to support women experiencing violence, however, is also the lack of recognition and resourcing of the role that they can and do play as part of the overall family violence support system. On the other hand, things that made it easier for settlement and multicultural service providers to support women included training, and the service providers we interviewed and who responded to the survey highlighted the importance of this training being regular and repeated because of the turnover of people in frontline positions. They also emphasised the need for training about family violence to be tailored to the issues that are specific to migrant and refugee families, and that training reaches volunteers and frontline workers. In some instances, services had been funded to conduct often short time-bound violence-related projects, but this funding and ongoing funding was seen as central to the work being high quality and effective. Service providers also highlighted the importance of their manager and wider organisations being supportive of them doing this work, as seeing it as part of supporting successful settlement, integration and flourishing of migrant communities. And service providers working in the multicultural and settlement sector noted that they could make a unique contribution to increasing women's access to services because of the long-standing relationships of trust that they often had with communities, and that these relationships were fostered by having bilingual and bicultural staff. So I guess to finish, Virginia, we found that multicultural and settlement services are doing an awful lot to support women experiencing violence, but that they're often doing that without funding, sufficient training or support. And there's an enormous opportunity to build on what they already do. And in part, this will be done by taking meaningful steps to strengthen relationships, coordination and two-way learning across the family violence and multicultural and settlement services.
Thank you again for that a very detailed overview of your key findings. I think what's quite clear from, or evident from your research is that a single focus approach that leads to that superficial separation or siloing of services is quite problematic, and that multicultural or migrant and refugee women often have complex needs, and those complex needs need really well-coordinated and sophisticated solutions that, and that includes a workforce that can work across all of those complexities. So thank you for that, Cathy. We're now going to hear about how refugee services are currently responding to domestic and family violence. And I want to start with you, Daniela. You're a senior social worker at the Refugee Health Service in South Australia. How does your service respond to disclosures of domestic and family violence?
Oh, thanks, Virginia. But before I commence, I would like to provide a brief overview of Refugee Health Service for those who may not know what we do, because our service is actually quite unique in South Australia. Refugee Health Service is a state-funded primary care service for newly arrived refugees and asylum seekers within SA Health. We have been supporting refugee clients in South Australia for over 25 years, and we provide early intervention, health and psychosocial support for people from refugee backgrounds but with complex health issues. And we support families and individuals within the first 12 to 24 months after arrival, and then link to community GPs and other multicultural service providers. We work in a multidisciplinary team consisting of doctors, nurses, allied health staff of social workers, clinical psychologists, bicultural workers, and admin team with visiting psychologists. So let me explain how Refugee Health responds to disclosures of DV. Now, our response varies according to the type of presentation and at what stage women are in their resettlement process. We always assess the safety risks in all types of presentation. Due to risk factors, DV referrals are reviewed by the allied health team and allocated as a matter of urgency to either a social worker or psychologist for assessment. The social workers and psychologists work closely with our bicultural, bilingual team members who are pivotal to the work that we do. They are our cultural and language bridge who enable us to connect and develop trust and safety more quickly with clients. We assess a woman's safety according to the Family Safety Framework guidelines in South Australia. Our role here at Refugee Health Service is to assess, educate and provide information about family violence and then refer to DV services or multicultural service providers. Refugee women require more support to navigate and understand the DV service system. Unfortunately, mainstream DV services are overstretched and they are under-resourced. And given the complex issues of our refugee clients, the way services are funded and structured makes it difficult for refugee women to access the support that they need. It is a reflection of policies where one size fits all. If families are assisted by AIMS, which is Adelaide's settlement service provider, then we liaise with caseworkers. If the family is in post-settlement, then we liaise and refer to post-settlement service providers. Living in a smaller city, we are fortunate to have good working relationships with AIMS, multicultural service providers and DV service providers. We rely on these services to provide support to women experiencing DV as they are our referral pathway. But the difficulties we encounter when referring to other services is when women choose to remain at home with a perpetrator, and often this is their preferred option, or if the perpetrator is her teenage son under the age of 18, this creates other challenges. There are also restrictions to some counselling services where only the woman can be seen, but not the rest of the family, which is not how family functions. And also there are long waiting lists for counselling. These become barriers, and we find that there are limited referral options for women who are not in immediate crisis. Thanks, Virginia.
Thank you for that, Daniela, and thank you for explaining the multiple and client-centered approaches that your agency applies, which show the significance of interagency collaborations that actually provide holistic services to migrant and refugee women. Yes. I'm just going to ask you something else. As your agency, the Refugee Health Services, as does most settlement services, works with the whole family.
Yes.
The perpetrator of domestic violence may also be your client. How do you manage this?
Yes, our agency does work with the whole family, and we do recognise the contributing factors and impact of the additional pressures of resettlement on family functioning. We are aware of the changing role of men in Australia and behaviour that was socially acceptable and common practice pre-migration can conflict with Australian laws and be illegal here. So, responding to the perpetrator, who is also our client, depends on the outcome of our assessment, the request from women, and our obligations to the legal processes. So, for example, if there is an interim order by police or the courts, we have to abide by that legal order. This means that the man is transferred to another medical clinic for his ongoing care, and we also liaise with other multicultural service providers for support, which is challenging as there are not many bilingual programs tailored for this group of men who use violence. Once DV is identified, client files have an alert system so that staff members are aware that there are DV issues in the family, and we continually provide ongoing monitoring regarding safety issues when clients attend our service. If the woman does not want us to address the issue with her husband, we discuss safety plans with her and obtain consent to inform their settlement case manager for further support. We also explore with a settlement service provider the possibility of further general group information sessions regarding DV laws to again include these men in sessions without breaching any confidentiality. It is easier if the woman requests assistance to talk to her husband, but then we have to assess risk factors, as disclosures can increase violence at home. We work with our bicultural workers to provide support by educating the husband regarding Australian laws. We also have a very strong focus on respectful relationships, which enables families to function in a healthy and acceptable way. But men who have not had positive role models require support to understand what healthy, positive relationships look like. We find that there is an enormous gap in the system for tailored bilingual programs to assist these men. Thanks, Virginia.
Thank you again for that, Daniela. Now, I want to turn to you, Xavier. You coordinate the Bicultural Community Health Program at the Australian Red Cross in Tasmania. This service provides education to multicultural communities on health issues. How was domestic violence identified as an issue that needed to be addressed in your programs? And if you don't mind, can you explain to us what steps did the program take?
Thanks, Virginia. So we, like the service in South Australia, we're funded by the state government in Tasmania. We also use a bicultural health worker model. And I regularly consult as a coordinator who's not from one of the communities, but is to enable the work that they do with their people, consult our team of bicultural health workers on priority issues concerning their community members' health and well-being. So our workers work with the sector and they work with their community members as well. So there was up to a certain point in time, I think our team had traditionally worked on primary health issues, which were physical in the main, things like diabetes, cardiovascular health, sexual health, education as well. But this time I said, think more broadly about people's health and think in a social determinants type of frame. And unanimously all the team members said that family violence was the greatest health risk that got in the way of the well-being of community members. So we began to really think about our place in the sector and our strength in working with community. And all the team undertook more domestic violence training for workers in the sector. We discussed the dynamics and the nuanced complexities within each community around that violence, and we became more aware of specific forms of gendered violence that existed, including forced marriage, through training that we gave to our workers as well. We became involved in the Aspire project that Dr. Cathy Vaughan mentioned earlier, and also the MuSeS research project, which was discussed a little earlier. And our workers gained a lot more broader insights and training in what domestic violence is and how it presents itself. And just I suppose, their own lens of viewing things within their own communities. We've also made resources more accessible to communities in the form of audio files. So during this COVID time, we've tried to make audio files that can be shared by social media in collaboration with the domestic violence education sector. And we also began to pilot and were able to bring into being a program called Peaceful Pathways, which uses a process called the Alternatives to Violence Project, which experientially gives people tools to deal with interpersonal conflicts.
Thank you for that, Xavier, and for explaining the steps that your programs took. I think that actually highlights the significance of consulting with people who are actually on the front line and following their guidance and letting them direct you on what their needs are and what is needed to actually address them. Can I just ask also, did you have to approach domestic and family violence education differently compared to other health issues? And was there different organizational structures implemented or any unique aspects that you had to consider?
Yeah, great question. Thanks, Virginia. Definitely. I mean, we had to consider the personal safety of our workers. This was a very different kind of inquiry compared to, engaging with people around, say, cardiovascular health. Educating people on something that can be quite personal and hidden like this was going to impact our workers. So we had to speak with each of our workers about considerations of safety, so plans that we had, and also just open up the lines of communication so that they ever sensed their own personal safety was going to be at risk or there's something they didn't want to do, that they definitely didn't have to go anywhere with it. And we think of another strategy. We also had to think about how to prepare and present resources in ways that keeps people safe. So I did mention the audio resources before. It means that people can access these things in their own time. We also have safety messages at the start, just saying the information here might compromise you if you're not by yourself or you don't feel safe. So make sure you find a space and a time where you feel like you can listen to this by yourself and take in the messages clearly.
Thank you again for that, Xavier. The pivotal role of bicultural and bilingual workforce is something that is also very clear from the research, and the panelists have touched on this so far. Fatima, I'd like to turn to you for further insights about this. You work for the same organization as Xavier, and you're on the front line as a bicultural worker in the community health program. We're interested to know, what training did you have or did you receive around domestic violence, and how has this helped you with your community?
Thank you, Virginia. Regarding the question, one of the formal trainings that I received was domestic violence alert, which builds more knowledge of the subject to me and how much different is women's rights here in Australia in compare with their country or the country that they lived before. And also, it developed my capacity of my role as a community frontline worker to provide appropriate support to women and children and to those clients who were suffering from family violence. I learned what would be the sign of domestic and family violence and how I can respond to it and refer them to the appropriate services. Later on, I took part to Forced Marriage Conference in Sydney. In 2 days conference and workshop, I found many information and knowledge about when someone is forced to get married without freely and fully consenting. During the workshop, we had some case study, and I disclosed that I know actually the forced marriage is ongoing issues in some families in Launceston and in a specific culture and community. The people around the table encouraged me to report them to police and to my work manager in Red Cross. First, I talked with our team coordinator, Xavier, in Red Cross. After some meeting regarding the issues, Red Cross provided many different types of support, such as the healthy relationship information session for all community members, and that I was interpreter and I was also co-facilitator for those workshops. And also we run AVP, that was the Peaceful Passive Project with communities to decrease conflict and violence in the family and even in the community. Through all process, in order to support victims, I had consultation with police, lawyers, counselors at Sonic Center, and caseworkers in Red Cross. My education and confidence grew up and built more to how can I actually support and help to victims and specific women and children. And considering my safety as well, by having safety plans, I experienced getting advice from Red Cross lawyer in one of the case as a family violence to keep my safety safe in the community. That was so important for me to keep my safety and also my influence in the community, as my role is in frontline worker who deal with families directly and have more interaction and connection with them. I also involved in MuSeS project and research, and this workshop helped me to develop an in-depth understanding how multicultural and settlement service supports immigrants and refugee women experiencing violence and what issues they are experiencing. During COVID-19, currently, I'm getting involved in adapting resources and sharing and translating the resources about family violence in my languages to the community members. With this experience, I found a deeper understanding of what domestic abuse is and how to get help for victims. Thank you.
Thank you for that, Fatima, for those insightful reflections and letting us know the training that you undertook. I think those reflections really highlight the importance of willingness by services to not only train the bicultural multilingual workforce, but also to build skills, and that this should be fundamental, not really just like an add-on, that upskilling is really needed, because this means that bicultural workers are not only going to remain at the front line, but they can also be involved in the decision-making process, in the policy change, and agenda setting. This ensures they are, so to speak, at the table. So thank you for that. I now want to move on to a very significant part of the research and the report. These are the recommendations that it makes for policy and practice change, and there are a number of these. Adele, I'd like to invite you to speak to us about this, but because of time constraints, perhaps you could tell us a bit more about two of the recommendations. The first one that you made being building the bilingual bicultural workforce within the family violence sector, and also strengthening collaboration between the family violence sector and the multicultural and settlement services sector.
Thank you very much, Virginia. I'd like to first acknowledge that I'm calling today from the unceded lands of the Wurundjeri people of the Kulin Nation, and pay my respects to elders past and present, and to any Aboriginal people listening in today. Our research identified many strengths within the multicultural and settlement services sector. And one that really stood out relating to addressing family violence was the employment of bicultural workers within these organisations, and it's been great to hear a little more about that today. Bilingual bicultural workers were highly valued by multicultural and settlement services. They were described as pivotal, and one service provider said they were like a cultural bridge and a language bridge. So I guess that draws a really clear picture. There were other benefits that were identified, such as having a good understanding of the cultural and migration context within which the violence was occurring, and of course within which the woman was receiving the support. Also, another benefit is cultural identification with the worker, which can help build trust and facilitate disclosure. There's also the factor of connection with the community. So the person is not just coming from the outside in a didactic way, but had some knowledge of the issues, and sometimes those issues are shared, which can be a really good basis for rapport and trust. Organisations that offer bilingual bicultural workers provide clients with a choice of working with someone from their community, or of course not doing so, but at least the person has the choice. It's also a demonstration to clients of equitable employment practices within the organisation. And I guess on the flip side, a demonstration that, for services that don't employ bilingual bicultural workers or migrant workers more generally, are demonstrating inequitable practices, which can mitigate against trust. We've suggested from our recommendations that these same benefits could flow to the family violence sector. If learning from the multicultural and settlement services sector, they could build their capacity to recruit and retain more bilingual bicultural workers. But of course that wouldn't be enough. Alongside the increased recognition of that important role, family violence organisations should also review their employment and recruitment practices. Currently, their employment practices do not attract or retain significant numbers of staff from migrant and refugee communities. So I guess, we've talked a lot over the last week or so in the community about systemic racism. And I guess it's worth acknowledging that it exists not only in policing, but also in our workforces and in our workplaces, including in the family violence sector. So there are relatively low numbers of bilingual bicultural workers and workers from migrant communities more generally employed in the family violence sector. And those that are employed tend to be concentrated pardon me, not in decision-making or senior roles. There aren't that many CEOs of family violence services who are from migrant communities, but they tend to be in frontline, part-time, and with casual hours. So our recommendation is that family violence services review their workforces with an intersectional lens and put in place employment practices that support equitable recruitment and retention outcomes, that build leadership of migrant women in particular within family violence services, that value the skills that bilingual bicultural workers bring, and also that respect them as a professional workforce. The second recommendation that I'll talk about also looks at the strengths of both the family violence sector and the multicultural and settlement services sector. So the family violence sector has very robust safety protocols in place to increase the safety of women and of workers. So they have, we all know, formalised risk assessment, referral protocols, training programs, formal debriefing and supervision. And through our research, we found that certainly this was the case for some multicultural and settlement services as well. So they also did risk assessment. Some had access to formal debriefing and training, as some of our speakers have spoken about already. But what we found was that these practices were not consistent within organisations or across the sector, and did rely too much on staff members taking it upon themselves to learn through experience, to upskill, or to follow working protocols. I think Cathy has mentioned how training did not really necessarily reach all those who most needed it. So we also found that although multicultural and settlement service providers didn't have systematised referral protocols across the sector, there were regular referrals to family violence services. And on the downside, there was a low confidence level. So only 32% of people, service providers making the referrals, had confidence that mainstream family violence services would be able to provide an appropriate or effective response to migrant women. So there's certainly some improvements that can be made within both sectors. And we think that enabling more collaboration would certainly strengthen both sectors. Through the research, we heard about some very effective collaborative working practice, such as co-working, for example, where multicultural and settlement services continued working with women even after they were referred to family violence services. And what the reason for that was to provide continuity, as well as cultural and linguistic support, and all those other benefits that we spoke about throughout this webinar. So these are really good indications that we can get very good outcomes for migrant women if we adopt different and collaborative service models. Single issue service response is not effective because that is not actually how migrant women experience their lives. Collaboration between the sectors would enable services to work together consistently and following the same frameworks and toward a shared goal. The frameworks do, of course, need to be adapted. We can't just pick whatever frameworks are there and just bring it into the settlement sector or the family violence sector, because we really do need to make sure they meet the needs of migrant and refugee women experiencing violence. But that also could be a collaborative piece of work. Greater collaboration would certainly enable the sharing of different expertise and resources that each sector brings to the table.
Thank you for that detailed discussion, Adele. For me, this discussion that you've just engaged in really reinforces the imperative for systemic change in this space. That we do need to make changes to the way that we've always done things, of siloing these various services. What we need are agencies that actually build on the obvious diversity required by the system itself or by systems, and also services that reflect the complexities of migrant and refugee women's experiences. So thank you for that insightful discussion. Before I turn to the panel for an open discussion, I just want to mention a couple of things. First, to remind the audience to submit your questions to the panel by clicking on that blue icon box at the top right-hand corner of your screen. But I also want to apologize in advance because we're running a little behind, so we will go about 5 minutes over time, so just bear with us. So now I'd like to open up the discussion to the whole panel by asking a few questions, including some questions from the audience as well. If I just want to ask the panel how your services for those practitioners who are on the panel, how they collaborate with the Givi sector to strengthen referral pathways, or for Cathy and Adele, what your research found about these collaborations, and what further opportunities would you like to see happen or be implemented? Xavier, do you mind starting us on this discussion?
Xavier? Yeah. So thank you, Virginia. So, yeah, definitely. I suppose we do have times where not hearing something is a bit of a concern. So during this period of COVID, in particular, our team's been really active in connecting with each other and speaking about what they're seeing. One thing that they said that they weren't seeing was an increase in domestic violence, so they weren't really seeing any concerns around that. And that in itself was a worry when we know that there's an increase in violence happening and an increased demand on services. So we've been trying to get messages to people directly in a way that makes them feel safe. So earlier I just mentioned some audio resources, and we were just looking for ones that would really, I suppose, take the opportunity to educate people, but also help them make choices. So one that we focused in on was made by the Human Domestic Violence Service. It's called Red Flags, recognising warning signs in an unhealthy relationship. So, and we managed to turn that into a plain language script. So it was quite a detailed document, and we wanted to make it, I suppose, we didn't want to compromise the messages within, but it was a bit long for, a focused listening in for someone who's beginning to engage with the subject matter. So we worked on a script, and it was run by their board, and they okayed it with a couple of changes, and our team then recorded it in about 10 different languages, and that then went out, and our team's been communicating with their people through social media, through WhatsApp, through Viber, Messenger, and other means. It'll go up on the website of the provider, and with like a safety message preceding the messages within the document, asking people to find that safe place where they feel comfortable and not pressured by someone else to take in the message as well.
Thank you for that detailed explanation, Xavier. Adele and Cathy, did you want to add anything about whether or not your research found any collaboration with the Givi sector to strengthen referral pathways or further opportunities that you might want to see happen or be implemented?
I think the co-working was one of the really that I mentioned before, was something that I think we could really look at more and expand further. There were also warm referrals. I know that this happens in a range of different sectors, but the way we think about referrals is often to just give a phone number to a woman and then she contacts the service. That's been shown not to work at all very well with migrant women. So I think that if we were able to do more warm referrals between multicultural and settlement services and family violence services, that would make a difference to migrant women.
Yeah, I think this is Cathy here, Virginia. I think just to totally agree with what Adele said in terms of the research finding the importance of warm referrals. and that it's not just a one-off referral and that people are left. Where it's been successful, the Settlement and Multicultural Services make a referral and then really walk alongside a woman as she's navigating the specialist family violence services, and often are able to advocate for her and support specialist family violence services in their navigation of things like the immigration system and areas where settlement and multicultural services often have more expertise.
Thank you for that, Cathy. Now I'm just going to ask if we've got time for about 2 or 3 questions from the audience. The first one, perhaps, I might direct it to you, Adele, or Cathy, or anyone who might actually feel like jumping in. The question is, are there any services that provide culturally appropriate DV services, as most services tend to use feminist theory that may not work for women from CALD backgrounds, and as a result, CALD women are less likely to seek or to ask for support?
Thank you for that question. I think the way that I would think about this is that culturally appropriate services and feminist-based services are not mutually exclusive. And in fact, for migrant women who experience both gendered and race-based discrimination, it's imperative that we use a feminist theory that acknowledges both factors. So it needs to be culturally appropriate, and it needs to address racism and race discrimination as a barrier, and it also needs to address gender discrimination as a barrier, and use feminist theory. So I think the opportunities here to do both, there are especially migrant women family violence services that do both, and we can certainly take our lead from them. There are some key services around Australia that are leading the way in this respect. So yes, it's definitely let's do both, and we need to bring that into both family violence services and to multicultural and settlement services.
Thank you for that discussion. I might just quickly move on to another question, so maybe we can fit in a third question. Adele, one of your recommendations that you mentioned, that you talked about earlier, called for an intersectional lens. Now, centering diversity in our services demands an intersectional approach, and we all agree with that. It also demands that the project and service design include perspectives from a myriad of client groups. Going forward, how do we build services that reflect this change?
Yes, so I think it does certainly have 2 aspects to it, and one is looking at the systemic discrimination and how our organisations can tend to perpetuate the same discrimination that a woman experiences outside of our organisation, even within the organisation. So organisations have to work really hard, actually, to provide services in ways that don't perpetuate that discrimination. So that's certainly something that through policies, through practices, through employment, equitable employment that we talked about before, make a huge difference to migrant women accessing services. So addressing systemic discrimination within our organisation, addressing it in our advocacy as well. So not only looking at, say, family violence legislation and how that impacts on women, but also addressing those kinds of policies that impact on women who have precarious migration status. That has to be a part of the advocacy that we do as well. So they're just some ideas of how we can take an intersectional approach in programming, in organisations, and in our advocacy.
Thank you for that explanation as well, Adele. Do the practitioners on our panel want to add anything to what an intersectional approach might look like as we build service designs that reflect the myriad of client service groups? Okay. Perhaps we might move on to, we might have time for a couple more questions. We have a live question from the audience. How do we work within a strength-based approach rather than the helping narrative when working with migrant women and refugee women? Perhaps this might be a question for our practitioners on the panel. Xavier, do you want to maybe kick us off and sort of thinking about what a strength-based approach might look like in this space?
Can I just check what I heard? What are the strengths-based approaches that would help working in this space? Yeah. Okay. Thanks, Virginia, and thanks for the question, whoever posed it. Look, the most strength-based approach that I know of is to use a bicultural worker. I don't know how many of you have access to bicultural workers in the sector, or that you're aware of in the areas in which you work, but the likelihood is that there is a service that can provide some support, a health service in your state. If not, I think it's something we should always be pushing towards, or we should be asking for the employment of a bicultural worker within our workforce, or to be able to consult people within the sector, to train people within the communities, and to seek their input, because otherwise I think we're moving in an ill-informed way, or an uninformed way, towards responding to issues that we won't understand the nuances around.
Xavier, it's Daniela here. Can I just add to that as well, because I totally agree with you. Working with bicultural and bilingual workers, it's really about the language that is used, that clients have shared their experience and they understand how to frame the information that makes sense in their life and their experience. Because unless the information is framed in a way that makes sense, it's foreign and they can't use it. So having those bicultural workers in the workforce working alongside other professionals is really, really pivotal to the work that needs to be done in this sector.
Thank you, Daniela, and Xavier, for those insightful explanations or responses to the audience questions. Now we're just coming to the end of our webinar, and I'm just opening it to the panelists if you have anything to add or sum up our discussions today.
Thanks, Virginia. It's Cathy here. I was just going to respond to one of the questions that have been sent in ahead of time in relation to whether we received any feedback in the research as to whether women preferred to receive support from an ethno-specific or a mainstream service provider. And I think the first thing to say is the focus of this research was really working with service providers rather than directly with women, as much as it has been in some of our previous research. But from the women we spoke to and from our previous work, I think the key thing is that women have choices, and that for some women, engaging with bicultural workers in their own language in an ethno-specific service would be their preference, and for other women that they may, for a whole range of reasons, prefer to engage with a mainstream specialist family violence service where they feel perhaps their confidentiality might be protected, or they feel safer in engaging with that space. So I think making sure that women have the right to engage with more than one service would be my key message there, and it speaks to Adele's point about having an intersectional lens. Not all refugee women are the same. Not all women from a particular ethnic or cultural community are the same, and therefore they need to have choices to be able to get the help that they need at the time they need it. Thanks, Virginia.
Thank you very much, Cathy. Unfortunately, we've run out of time. I would like to say thank you to the audience for submitting questions during the webinar as well as beforehand. And thank you to the panel for sharing your insights and knowledge about this important issue. Before we end the webinar, let me also acknowledge once again the important work that is already happening on the ground. As Cathy mentioned at the beginning, we know that there are many organizations that could not be part of this research or the webinar, but who are already doing this work on the ground and making some significant inroads. We also want to bring to the audience attention, for example, some of the work that Settlement Services International has recently commenced as part of an ARC grant and in partnership with the University of Wollongong, and I believe it's being led by Joe Spangaro from the University of Wollongong. This research is going to test acceptability of screening and rates of disclosure of domestic and family violence in the humanitarian settlement program. And it's a really interesting piece of work. For anyone who's interested in this emerging piece of work, please feel free to contact Dr. Astrid Perry, P-E-R-R-Y, at ssi.org.au. She'll be happy to discuss it further. So thank you again to the audience for watching this webinar, and again to our panelists. Remember, the webinar is being recorded, and the recording will be available on the ANROWS website for on-demand viewing in a couple of weeks. So please feel free to tell your colleagues and networks who could not attend the live webinar today. And also, just a quick reminder that the report for this research is also available on our website. And final reminder being that the next ANROWS webinar will be next Thursday, the 18th of June, and it is titled Working with Women Who Have Experienced Complex Trauma in Mental Health and Refugee Services, a Comparative Discussion. Please visit the ANROWS website for more details. Virginia Mapezama, on behalf of ANROWS, thank you all and goodbye.